Okay. So good morning, everyone. I am Dr. Jenny Ai from Respiratory Team. So I'm going to deliver two lectures. First is the pneumothorax and pleural effusion, and the second one is interventional pulmonology. So I will go into the pleural disease first. So pneumothorax and pleural effusion are the most common pleural disease that we encounter day in and day out. So this is a very important topic for you as well. So what is pneumothorax? So you can see this chest X-ray show hyperlucency over the apical area. So pneumothorax is air in the pleural space by definition. And there are two types of pneumothorax. First is the primary pneumothorax. That means it occurs in a normal lung. And the second one is secondary pneumothorax. That means the pneumothorax occurs in the presence of underlying lung disease. So by etiology, they can be classified as spontaneous or traumatic cause. So what are the causes of pneumothorax? So for primary, the pathogenesis is poorly understood, but they are presumed to occur following an influx of air from the apical bulla. So there is a apical bulla in the anatomy, and then suddenly it bursts, and there's air leak occur and cause the primary spontaneous pneumothorax. So for the secondary one is the causes are more defined. It usually occurred in diseased lung. So if the lung has some problem, underlying problem like COPD, asthma, or interstitial lung disease, pneumonia, or tuberculosis. PCP is the pneumocystic pneumonia. So cystic fibrosis, Langerhans cell histiocytosis, and lymphangiomyomatosis are some cystic lung disease. So that's cyst in the lung, and it bursts, and then it causes pneumothorax. So other rare causes are Marfan syndrome, esophageal rupture, lung cancer, catamenia, pneumothorax, and pulmonary infection. So these are less common causes. Sometimes pneumothorax may be the first presentation of the underlying lung disease. That means a patient presents with pneumothorax, and then you diagnose like tuberculosis afterwards. So this may be the first presentation of the disease. So, of course, chest trauma will be one of the causes, and iatrogenic causes like chest ring insertion, and then we heard the visceral pleura, or during pectoral insertion and the visceral pleura is hurt, and then there's a pneumothorax occur. For the primary spontaneous pneumothorax, it usually occurs in the tall young gentleman, aged between 20 to 40, and a thin gentleman. So the proposed pathogenesis is that because of the tall and thin habitat, so there's apical bulla over the lung apex, and then it suddenly bursts, and then air go into the new pleural cavity. So smoking is definitely one of the major risk factors for pneumothorax. There is increased risk of pneumothorax by a factor of 22 in men and 9 in women. So if patient got a spontaneous primary pneumothorax in a young gentleman, the first advice would be to quit smoking. So how do they present if they got pneumothorax? So that is a very typical presentation of acute onset of thoracic chest pain and also shortness of breath. Patient can tell you like, now 11 o'clock, suddenly I feel right side chest pain, and then associate with breathlessness. So this is a typical presentation of pneumothorax. So the sign of pneumothorax include tachycardia. You can see that there's reduced chest expansion. In the chest examination, there's hyperresonance percussion notes, or even quiet breath sound because there's no air go in there. So sometimes if the pneumothorax is very severe, there's subcutaneous emphysema. That means the air goes to the subcutaneous tissue. You can feel the bubble under the skin. So it can present with acute clinical deterioration in a ventilated patient. That means in a patient, if the patient has other disease like asthma or pneumonia, they are intubated, and then there's suddenly acute deterioration. Then we have to take the chest X-ray, urgent chest X-ray, and also examine the chest to see if there's pneumothorax occur, causing sudden deterioration. So one of the important points you have to learn is reading the chest X-ray. So when you become houseman, you read chest X-ray. One of the most important things you have to look for is pneumothorax, because it have to treat immediately, otherwise patient will deteriorate and it's fatal condition. So what is the sign of pneumothorax in the chest X-ray? So first of all, you have to know to look for pneumothorax, we have to order an upright PA chest X-ray in inspiration. So this is the modality of choice. And then you can see, when you read the chest X-ray, you compare the both sides, bilateral side. So you can see, okay, here there's lung marking, but here you already see some hyperlucency. So when you compare both sides, you can see there is a hyperresonance, a hypertransparency here. So that is reduced in lung marking over the lateral side, and you look for the pleural line. The pleural line, normally you cannot see the pleural line because the lung is fully expanded. There's normal lung marking, but on the right side, you can see there's a pleural line like this. So outside the pleural line, there's absence of lung marking. Or when you read the chest X-ray, you can see that there's lung marking, and then there's sudden abrupt change in radiolucency. So this is very easy. It's very easily detected in the chest X-ray. But sometimes it's not very prominent. So it only occurs in like this X-ray show left apical pneumothorax. So it can be detected by comparing both sides of the lung. So you can see, oh, there's an increase in radiolucency over here. And when you look in more closer, you can see there is a pleural line over here. So this is a small pneumothorax in the left apical region. And if patient take a chest X-ray that is supine, and then it's even more difficult to detect pneumothorax. So be aware that this chest X-ray is PA, erect, or is supine. If it is supine, then we look for deep sulcus sign. That means there's decreased radial density and deep costophrenic over the deep costophrenic angle. So you can, when you compare these both sides, you can see the costophrenic angle is the radiolucency is different. It's increase in radiolucency, and there's a deep sulcus sign here. So it's more prominent. The CP angle is more prominent. This is result of intrapleural air that collect basally and anterior in the supine position, because when you lie down, the air will go up, right? So it's more prominent in the anterior position, so causing the deep sulcus sign. So what is the treatment? So I have mentioned that pneumothorax deserve immediate treatment. So you have to, as a houseman or medical officer, you have to look at the chest X-ray very carefully to exclude pneumothorax. So there's a condition called tension pneumothorax. That means the pneumothorax is so big that it's pressed on the mediastinum, and the mediastinum is shifted to the contralateral side like this. You see the heart and the trachea is shifted to the contralateral side. So this is a very fatal condition. If you not treat the patient will die because of the hemodynamic compromise. So for the treatment of pneumothorax, it depends on the size and also depends on the patient characteristics. So we will talk more about this. And basically, the therapy has two goals: is to remove the air from the pleural space, and also the secondly is to decrease the likelihood of recurrence, because for the secondary pneumothorax, the recurrence rate is very high. So first of all, when you look at the chest X-ray, you have to estimate the size of pneumothorax. So please remember, when we read the chest X-ray, this is a PA film, it's two-dimensional only. So how to estimate the size of pneumothorax? Like this diagram, you can see this is the normal lung pleural line. So when you measure it, it's 10 cm from the medial border. So if you have 1 cm pneumothorax like this, so what is the size? Can you estimate the size of pneumothorax? I mean the volume of pneumothorax. 10%, 20%, 30%, or 40%? Anyone want to give me an answer? Or you can type in the chat box if you know the answer. Okay, so usually PA chest X-ray usually underestimate the pneumothorax. You read it, oh, it's 1 cm rim only. You think it's very small, but when you see look at the CT, it's already the volume will be, is underestimated. So this is the formula of estimating the volume of percentage of pneumothorax, but I don't think you need to really know the formula, but the magic figure is 20 cm. 20% in 1 cm pneumothorax. So if you see a 1 cm rim of pneumothorax in a PA chest X-ray, that means there's a 27% of pneumothorax already in terms of volume. So if there's 2 cm rim, then half of the lung is collapsed already. So you have to remember this magic figure, 20%, 27% in a 1 cm rim of chest X-ray pneumothorax. So treatment option, first of all, you have to give oxygen immediately, and then we have to find a way to remove the air from the pleural space. It can be done by simple aspiration or tube thoracostomy. And then later we will give some pyrolysis agent, or for tube thoracostomy. After that, after lung expansion, we can give the pyrolysis agent through the fluoroscopy or through surgery. So oxygen and drainage of air is most important. So how important is the supplementary oxygen? If we give oxygen, high flow oxygen, then the absorption of pneumothorax can be fastened by 4 times. So for very small asymptomatic pneumothorax in like a healthy young man, then we may not need chest ring or a simple aspiration. We just give oxygen and then let the pneumothorax absorb by itself. Sometimes work. So oxygen is important, and it is especially important for patients with respiratory failure. So the other treatment is simple aspiration. So if we decided to remove air from the pleural space, then for the primary spontaneous pneumothorax, the treatment option, the first line treatment would be simple aspiration. So For the secondary pneumothorax, if the pneumothorax is very small and patient is relatively asymptomatic, then we may choose simple aspiration. But usually it will fail because the lung is quite bad. The underlying lung is diseased. So usually simple aspiration in secondary pneumothorax is fail. But primary pneumothorax will be the treatment of choice. So how to do it? We usually do it in the second intercostal space, use the 14 to 16 gauge of needle, and then stuck in there and then aspirate the air as much as we can. However, if patient present with respiratory failure or even hemodynamic unstable, then we may need chest string right away. The chip thoracostomy is the chest string. So there's some literature showing that simple for primary spontaneous pneumothorax. So primary, that means young gentlemen without underlying lung disease. For primary spontaneous pneumothorax, simple aspiration is as good as chest string. And the good thing is that the wound is smaller and less painful, and there's no need hospitalization for the primary spontaneous pneumothorax that can be treated by simple aspiration. So the third treatment is chest string insertion. So first of all, you have to know where to put the chest string. Of course, when you read the chest X-ray, you have to identify, oh, this is right side pneumothorax or left side pneumothorax. But for example, you know, okay, this is left pneumothorax. So when you decide to put in a chest string, you have to know where should you put. Where is the safety triangle? So please remember this safety triangle for your whole life. So the anterior border is the pec major, lateral border of pec major. And the posterior border is the lateral edge of latissimus dorsi. And the upper edge is the base of axilla, and the lower edge is fifth intercostal space. So usually we can insert the chest string within this safety triangle if there's no ultrasound or CT or image guided. So this is the step showing the chest string insertion. So you have to know the anatomy first. When you, we usually put the chest string above the rib. The reason is that below the ribs, the neurovascular bundle. So you don't want to traumatize the nerve or the intercostal artery. So we have to palpate the anatomy. Like, okay, there's a fourth intercostal space, and then we palpate over the rib. We will insert the chest string over the rib, not below the rib. So first of all, we identify the anatomy, and then we apply the local anesthesia. Usually we give 1% or 2% lignocaine. And also we usually give it layer by layer. So the skin, the subcutaneous, the muscle, the pleura. So all layer we have to be infused with adequate local anesthesia. So after local anesthesia, we will use artery or Kelly clamp to do blunt dissection. So we dissect from the skin all the way to the pleura. When we reach the pleura, there's usually gush of air coming out. So that means we have reached the pleura already. So when we go back to the anesthesia, local anesthesia, when we stick a needle in, when we reach the pleura or reach the pneumothorax, we usually can aspirate air. That means this is the good site to put the chest string in. So aspirating air is very important in the test needle or the needle that you apply local anesthesia. So if there's no air, nothing can be sucked out, then you have to think, oh, is this the good site to insert chest string? Usually then, if not, then we have to change the position. So after blunt dissection, we will put the chest string in like this. So when we put the chest string in, the air can be drained out. So the chest string will usually connect to a chest string box. Usually it's like this. in the ward. But the free bottle system is the mechanism for the chest ring box. So you have to know, even though there's no free bottle system in the ward already, it's a very old classical chest ring box, but you have to know the mechanism. So first of all, the chest ring will drain the air here. So the first bottle is the drainage bottle. And then the second bottle is underwater sealed. So here is the underwater seal. We will pour some water here, so the air will drain here underwater. The underwater seals means that the air can not go into the patient through here, through the system. The air can go here, and then the air dissolve in the water, but it's sealed by water, so the air outside won't go back to the patient. So it's underwater seal system. So for the collecting chamber is here for the modern chest ring box. Collecting chamber corresponds to here, and the underwater seal here corresponding to here. And sometimes we have to add suction. So the suction control is over here. So we will add some water and then and apply the suction. So this free bottle system, you have to understand the concept. So what is the complication of chest ring insertion? When you become house officer, you have to explain the possible complication of chest ring. So the most important one is we have to explain to the patient there's a possibility of lung injury or blood when we incidentally touch the blood vessel, there's bleeding. And also there is a possibility of infection if the chest ring have put there for like more than 1 week. There's a risk of wound infection, empyema. And so most important is the organ injury, bleeding, and infection. So after we insert the chest ring, we would anchor the chest ring, and then also we will put this mattress suture, like a U-shaped suture. When we remove the chest ring, we don't need to reapply suture. So if the lung is expanded, there's no more air leak. We just cut this anchoring chest ring, and then when we pull out the chest ring, we will close the wound by this mattress suture. So this is a very important slide for you. This is the algorithm of management of spontaneous pneumothorax. This is stated in a British Thoracic Society guideline 10 years ago. There's updating of the guideline, but it hasn't been published. So we still based on this guideline for spontaneous pneumothorax management. So first of all, when you look at this algorithm, you have to categorize this pneumothorax as primary or secondary. So primary, as I said, is the pneumothorax occur in young, thin, tall gentlemen without underlying lung disease. And for the secondary pneumothorax, it's usually old. It's older than 50 and have history of smoking, or there's no underlying COPD, asthma, lung cancer, or other diseased lung. So it's classified as secondary pneumothorax. It is important to categorize as primary and secondary because the management algorithm will be different. So first of all, for the primary spontaneous pneumothorax, we have to estimate the size and also the symptom. If the size is less than 2 cm rim in the chest X-ray, or patient do not have any symptoms, then we can discharge and review in our patient. However, if the pneumothorax is bigger than 2 cm and or patient have symptom of breathlessness, then we have to remove the air from the pleural space. So as I mentioned, the first line treatment for spontaneous primary pneumothorax is simple needle aspiration. So you can do the simple aspiration. So if it's success, then we can discharge. But if it's not successful, painful, then we have to insert the chest ring. So you can see the chest ring size would be small bone is good enough for drainage of air. So this is the algorithm for primary pneumothorax. Okay, so for the diseased lung for older age gentlemen or ladies, patients have secondary pneumothorax, then we have to again estimate the size and the symptoms first. If the size is small, less than 2 cm, or without any symptoms, then we may consider simple aspiration. So the difference is that we can't discharge a patient with secondary pneumothorax anyway. If it's small without many symptoms, then we have to do something. We have to aspirate first, simple aspiration. If it is a success, then we can admit, we should admit. We cannot discharge patient, we should admit. If it's not success, then we go for chest ring. So in the country, on the contrary, if patient have big pneumothorax like more than 2 cm, or patient have symptoms, then we have to go to chest ring right away. Okay, so if it's less than 1 cm and without symptoms, we will admit. We will admit and observe. So the difference is that for secondary pneumothorax, because patient is older and the lung is not healthy, then we have to admit patient anyway. So for primary spontaneous pneumothorax, if the size is small and without symptoms, then may not need intervention. If patient got big pneumothorax and have symptoms, then we will try simple aspiration first. And for primary spontaneous pneumothorax, the rate of recurrence is lower than the secondary. For the secondary pneumothorax, we need intervention unless it is small and no symptoms. So if patients have no symptoms, we admit and observe. Otherwise, we need intervention. The first line of treatment will be chest ring insertion. So chest ring insertion will be needed in most of the case. And there's high rate of recurrence of secondary pneumothorax. It's almost more than 40% of recurrence rate. So we have to offer a treatment to prevent recurrence. We will discuss this later. So this shows the recurrence rate of primary pneumothorax is around 30%. But for the secondary pneumothorax, it's more than 40%. So how to prevent recurrence? For secondary pneumothorax, we, for both primary or secondary pneumothorax, surgical treatment is the option for prevention of pneumothorax. But sometimes patient is old, is not surgical candidate, then we will consider chemical pleurodesis. So for chemical pleurodesis, TAP is the treatment of choice. And for the evidence, actually most study is for pleural effusion, prevent pleural effusion recurrence. For pneumothorax data is not very strong, but this is still the most commonly used chemical pleurodesis agent for patients with secondary pneumothorax and is not fit for surgery. So please remember the first treatment of choice for preventing recurrence is still surgery. So there are other chemical pleurodesis agents like minocycline, doxycycline, and tetracycline, but the successful rate would be at most efficient would be TAC. So after the tetracycline chemical pleurodesis, you can see the recurrence rate is decreased for primary from 30 to 10, for secondary from 43 to 28. So, but for the surgical pleurodesis, thoracoscopy, like VATS with stapling of flaps or pleural ablation, the recurrence rate will be cut down to less than 5%. So surgery is a treatment of choice. So what is TAP? This is a tri-layer magnesium sheet silicate with significant lubricative properties. This is the main component of 爽身粉. So these are lubricating properties. But for chemical proteases, we usually use large particle talc. There's a small particle talc or a large particle talc, but because of the risk of ARDS, we usually use large particle talcs. So that's a decrease in systemic absorption and decrease the likelihood of ARDS. There are two ways of administering talc. First is a talc poudage. That means we will use atomizer or blood syringe to blow the talc into the pleural space, either by poroscopy or VATS. Or more oftenly, we will use talc slurry. So everybody have chest drain for the pneumothorax patient. We just mix the talc with lignocaine and saline, and then we can instill the talc through the chest tube. So talc slurry is the most common type of administration of talc in our clinical practice. So when you become houseman, we have to take consent for talc pleurodesis. So we have to explain to patient it's quite a painful procedure, but we will give some lignocaine to the solution. And there's a side effect of fever. It's not because of the infection, it's because of the inflammatory reaction. Sometimes patients have fever after the chemical pleurodesis. And as we are instilling some foreign material to the pleura. So there's a still risk of infection causing empyema. So the most concerned side effects of talc pleurodesis is acute respiratory distress syndrome, but the quoted percentage is very small, it's less than 1%. So the size of the talc particle is very is correlated with the risk of ARDS. So if we use the large particle talc for pleurodesis, in the case series, out of 500 patients, there's no patient having ARDS. So we are now using large particle talc for our clinical practice. So apart from ARDS as an acute complication, there's some long-term complication of talc. Some studies show that there's restrictive impairment after many years of talc pleurodesis. And also after administering talc and then patient go through the PET scan, then there is active uptake as well. So we have to ask, if there's a pleural uptake in the PET scan, we have to ask patient if patient got some recent procedure or chemical pleurodesis recently. So as I mentioned, surgical treatment is the treatment of choice for preventing pneumothorax recurrence. So it can be done with the wedge resection or some stapler to remove the bulla, and sometimes parectomy or installation of talc or laser ablation of parietal pleura or ablation with dry gauze. So physical pleurodesis is the treatment of choice during the surgery. So the rate of recurrence will be largely reduced to less than 5%. So what is the indication for surgery intervention in pneumothorax case? So first of all, if patient have the second times of easilateral pneumothorax, like in a primary pneumothorax patient, then we will refer to surgery. For the first episode of primary spontaneous pneumothorax, like a young gentleman, 20 years old, present with first episode of pneumothorax, we just drain the pneumothorax. As long as there's no air leak, we can remove the chest drain and then go home. If patient is smoking, then we will ask him to quit smoking. However, if patient got the second time of same side of pneumothorax, then we have to refer to surgery. or patient got first contralateral pneumothorax, then the risk of next time bilateral pneumothorax will be fatal. So we will refer to surgical intervention. Or patient present with synchronous bilateral spontaneous pneumothorax. Of course, we won't let the next episode of bilateral pneumothorax to occur. So we have to refer. And also, if patient got persistent air leak, that means we insert the chest string in, even the lung has been expanded, and there's still air leak from the chest string. That means the visceral pleura is not healed at all. Then if more than 5 days, then it's defined as persistent air leak. Then we have to refer to surgery. Or after we insert the chest string, the lung failed to re-expand and even apply the suction, then we have to refer as well. If patient present with spontaneous pneumothorax, then we have to refer to surgery, of course, because the bleeding is very alarming. And if patient is having professional risk like pilots or divers, then we will refer to surgery even they present with first episode of spontaneous primary pneumothorax. So we have to ask the occupation of the patient. If patient is pregnant lady present with pneumothorax, then we have to refer as well. So this is the bulla seen during the surgery. So surgeon will remove the bulla and prevent the recurrence. There's another condition called subcutaneous emphysema. That means patient have pneumothorax here, the visceral pleura is broken, and then the air go into the pleura. And then there's no effective drainage. Then the air will go into the subcutaneous tissue, causing the subcutaneous emphysema. So if we have inserted the chest string already, but the drainage is blocked or kink, the chest string is blocked or kink, then the drainage was not efficient, and the air leak will go through the least resistant pathway. That means the subcutaneous pathway. So it will cause the air inside the subcutaneous tissue go up to the neck or even the face. So this is the chest X-ray for subcutaneous emphysema. You can see there's air in the subcutaneous tissue, and the air over the neck. And clinically, you can see the patient is like blowing up through the face. The face is become swollen, and when you palpate the skin, there's subcutaneous crepitus. So for this clinical condition, the most fatal condition would be upper airway obstruction if the neck is, if the trachea is compressed by the subcutaneous air. So you have to immediately check the chest string. Usually the chest string is blocked or it's not working. Then you have to insert another function chest string. So the treatment would be relieve the obstruction, insert another chest string, apply suction, so the air can be drained efficiently over the proper channel through the chest string. And sometimes if the subcutaneous emphysema is very severe, causing compromising of upper airway, then we have to put in the subcutaneous drainage or a skin incision to let the air come out. So that's all for pneumothorax. So I think for pneumothorax, the take-home message is that you have to know the primary and secondary pneumothorax and the algorithm of the treatment. So for when you become houseman, you really have to look at the chest X-ray very properly to identify if there's any pneumothorax, because pneumothorax is an acute condition which is fatal. So I will go into the second topic, the pleural effusion. So pleural effusion is very important in pleural disease and very common condition. So what is the definition of pleural effusion? That means there's a extra fluid accumulated in the pleural space. Usually in the pleural space, there are around 20 ml of pleural fluid physiologically in the pleural space to act as a lubricant when we breathe. So for the pleural anatomy, the pleural cavity surface area is very big. And there's two types of pleura, visceral pleura and parietal pleura. So visceral pleura is enveloping the lungs and the fissure. Parietal pleura cover the thoracic cage, diaphragm, and mediastinum area. So usually in the pleura, there's a mesothelial cell with brushy macrolide. So this is the structure that balance the fluid inside the pleural cavity. So if there is a loss of balance between the in and out lymphatic drainage or the pleural fluid, then there is abnormal accumulation of fluid here. So this is just some basic anatomy. There's some protein in the pleural fluid, and there's some lymphocytes and red blood cell here as well. And this equilibrium will keep the pleural fluid at less than 12 ml of pleural fluid in the cavity. If there's any things disturb the balance, then it will cause pleural effusion. So one of the common type of pleural effusion is the malignant pleural effusion. So the pathophysiology is that there's a malignant pleural involvement. Either the tumor invaded directly from the neighbor structure, like from the CA lung, or some emboli to the of the tumor cell to the visceral pleura, and seeding the parietal pleura, causing this abnormal structure blockage of drainage, and then causing pleural effusion. The other one is the other cause is lymphatic blockage, because usually the pleural fluid will be drained by lymphatic system. If there's a malignancy over the lymph node causing blockage, then the fluid will accumulate. So this is again a very important slide for you. This is the management of unilateral pleural effusion in British Thoracic Society guideline. So when patient present with unilateral pleural effusion, so you have to ask the history. How acute is the symptom? Is there any evidence of symptoms suggesting heart failure or renal failure or liver failure? If yes, then you have to treat the underlying cause. This may be caused by heart failure, renal failure, or hypoalbuminemia, secondary to cirrhosis. Then you treat the underlying cause. If there's no obvious cause found in the history of examination, patient present with unilateral pleural effusion, then we have to do pleural aspiration. So this can be done with either in the bedside with ultrasound guidance, or by the chest X-ray, and then we stick a needle in. And then when we stick a needle in, we aspirate, then we have to know, oh, this is either normal pleural fluid or blood or pus, and we will treat accordingly. So during the pleural aspiration, we will send the pleural fluid for protein and LDH for Leitz criteria, cytology for malignant cell, and a pH, especially if it's suspected to be empyema or infection in the pleural space. We'll send a culture, and in Hong Kong, we routinely send TB as well, because TB pruritus is not uncommon here. So after reading the biochemistry, then we will know this is transudative or exudative. If it's transudative, then okay, we will go back. Oh, is it heart failure? Is it renal failure? Is it a cirrhosis patient? If yes, then we treat the cause. If this is exudative, then we have to look for the other cause of diagnosis. So we have to order a CT to look for malignancy. And also we have to do pleural biopsy. There are three ways of doing pleural biopsy, either doing bedside by Abraham needle, or image guided, either CT or ultrasound guided pleural biopsy, or using pleuroscopy or even surgery for direct visualization of pleura and then biopsy. If the cause can be found, then it treat appropriately. If the cause still cannot find after this extensive investigation, then we have to think of like PE, TB, or heart failure, lymphoma. So this is the important algorithm for management of unilateral pleural effusion. So there are different causes of transudative pleural effusion and exudative pleural effusion. So we have to classify this as exudative or transudative pleural effusion. So transudative is very easy. Usually heart failure, liver cirrhosis, hypoalbuminemia, or sometimes patients have a CAPD, peritoneal dialysis, and there's a fistula over the diaphragm and go into the pleural cavity. Less common causes are hypothyroidism, nephrotic syndrome, and PE. So rare causes, mixed syndrome, ovarian hyperstimulation, pericarditis. Mixed syndrome, that means patient have CA ovary and the patient got transudative pleural effusion in the pleura as a reactive cause of pleural effusion. So most important is knowing the cause of exudative pleural effusion, because the common causes are malignancy or infection. So we have to find the cause and treat it. So TB pleuritis will be another common cause in our locality. Less common cause are PE, rheumatoid disease, asbestosis related pancreatitis, or post cardiac surgery syndrome. So if we use, after extensive investigation, if we still cannot find the cause, we have to consider any drug for causing pleural effusion. So these are the common drug that cause pleural effusion. It's not really common, just known causes of pleural effusion. But this is by exclusion. So we have to find out if there's any cause of malignancy or infection first. So this is by exclusion, diagnosis of exclusion. So when you stick the needle into the pleural effusion, immediately you can examine the color of malignant pleural effusion. So what is the treatment for pleural effusion? First of all, we have to, if patient presents with shortness of breath and respiratory failure, then we have to drain it. We can do bedside tapping, pigtail insertion, chest string insertion, or fluoroscopy for drainage. And then we have to find the cause and treat accordingly. If patient have heart failure, renal failure, we just optimize fluid status. If patient have pneumonic effusion, apart from drainage, we have to give antibiotics. If patient having malignant pleural effusion, then we will refer to oncology. And also we can apply a TARP fluorodesis to prevent recurrence. So this is the pigtail drainage. Pigtail is useful for prevent easily dislodgement of pleural pigtail drainage from the pleura. And also there's some side hole to assist the drainage. So this is a pigtail. We use the Seldinger technique for insertion. So this is how the pigtail look like in the chest X-ray. So, the renal patient, they have the tank of insertion. For the malignant pleural effusion, we have this long-term indwelling pleural catheter. So this is mainly indicated for malignant pleural effusion, which is recurrent after drainage and is not responding well to the chemotherapy. Then we will insert a long-term indwelling pleural catheter. So it's very easy. It can be done in bedside. And under local anesthesia, the advantage is to reduce hospital stay. So patients do not need to admit to a hospital if the pleural effusion is recur, and they can drain as outpatient or even at home. So they can reach and also they can reach outpatient pleurodesis without chemical pleurodesis. So that means when we insert the IPC in and then patient have regular drainage, then sometimes it will achieve self-pleurodesis without giving any TAP pleurodesis. So this is mainly indicated for malignant pleural effusion and also trapped lung. Trapped lung means that a patient have pleural effusion after we drink all the effusion, the lung cannot expand because the visceral pleura is diseased. There's many deposit or inflammation there, and then it's just like the lung is wrapped by a 保鲜纸 and then cannot expand after we remove the fluid. So in the trapped lung patient, the fluid will recur after we drink. So this is good for IPC insertion because patient can drain at home. So this is mainly for the motivated patient because they have to drink at home. So they have to know how to take care of this catheter, how to drain. So the side effect or complication will be dislodgement, loculation, and infection. So this indwelling pleural catheter, IPC. So as I mentioned, bedside ultrasound is very important. So you can see this bedside ultrasound showing pleural effusion. This is the diaphragm, this is the liver. So this is the leg of the patient, this is the head of patient. So you can see the anechoic area. This is the pleural effusion here. So this is the lung. This is the lung in the pleural effusion. It's collapsed lung in the effusion. It's like a tongue-shaped structure in the pleural effusion. So fluid is anechoic in the ultrasound. So for chemical pleurodesis, as I mentioned, we can give through at the top. Powder can be given through the chest drain, or we can do the TAP slurry. This is the powder blower. When we do poroscopy, we can blow the TAP powder in. So we will, during the poroscopy, we can insert this powder blower, blow the TAP over the prostate. So after installing the TAP, you can see this snowy, snow-like appearance of TAP. The TAP is dispersing over the pleural space to achieve chemical pleurodesis. So I think I will stop here for pleural disease before I go on to the second lecture. So is there any question that you would like to ask? So if there's no burning question, then I will proceed to the second lecture. So if you think of any question that you would like to ask, then you can type in the chat box. So the second lecture will be interventional. There's some question coming up. So the first question is, do we need chest drain after aspirating the simple pneumothorax as what we do following needle thoracostomy? So simple pneumothorax, we will classify pneumothorax as primary or secondary. I presume you are asking primary pneumothorax, right? So if the simple aspiration is a success in the primary pneumothorax, that means the lung is fully expanded after you aspirate the air. And this can be done. This can be determined by the chest X-ray. So if the chest is fully expanded and there's no symptom in primary pneumothorax, then we will discharge patient, and no need chest drain insertion. So for the secondary pneumothorax, then it's different. After simple aspiration, we have to admit. So if it's assessed, then we won't need to convert to chest drain. Okay, the second question is for empyema, should we drain all the pus immediately, or do we worry about re-expansion pulmonary edema? Okay, so re-expansion pulmonary edema, this is a good question. And I haven't touched much about re-expansion pulmonary edema. So classical teaching is that even it's pus or fluid, we would drain 1.5 liter at once. And then don't drain over this amount because of risk of re-expansion pulmonary edema. But now nowadays teaching, there's more and more evidence that even though you drink more than 1.5 liter, it's still safe. So in our daily practice for respiratory, for pleural effusion or even pus, we will drink 1.5 liter first. And then if patient is still very breathlessness or in respiratory failure, then we will drink 500 ml per hour. We will stop the drainage, and then next hour will be 500 ml. Next hour will be 500 ml to prevent pulmonary edema. So usually pus usually in clinical setting, there won't be a large volume of pus, usually like less than 500 ml of pus. Then will be, the patient is already very septic. So we won't really drain 1 liter, 2 liter of pus. Usually it occurs for the drainage. We usually worry about re-expansion pulmonary edema in pleural effusion. It's not really in the empyema case. So the next question about the trapped lung. How to know when to suspect trapped lung for patient that has fluid retained in the pleural space, even after trial chest drain, instead of simply a recurrence or other diagnosis? It's very easy, trapped lung. For the diagnosis of trapped lung, after you drink all the pleural effusion, you can see an air space in the chest X-ray. So you have to think, is that iatrogenic pneumothorax? When we insert the pigtail, we heard the residual pleural, and then there's air go in there. So usually after drainage of fluid effusion, we see air in the chest X-ray, then we will convert to chest drain. So for pneumothorax, then we will see air leak. For trapped lung, there's no air leak. So this will help us to distinguish between trapped lung and pneumothorax. Okay. Some of you asked about the spontaneous pneumothorax. Okay. Spontaneous, how to distinguish primary pneumothorax? So I have to go back to the slide. Even if a man or a lady is the same, actually. Not all men, there's no sex discriminate. So, okay. So again, this is a very important slide. You really have to understand. Primary pneumothorax, that means it's young, there's no smoking history, no underlying lung disease. It's primary pneumothorax. So it's lady or it's gentleman or no problem. It meets this criteria. It's young and no smoking history, no underlying disease. It's primary pneumothorax. Okay, I think it's good. It's clear enough. So you have to know it's primary or secondary, then you have to know the size and symptoms, and then you decide the treatment algorithm. Okay, in the sake of time, we have to go to the intervention pulmonology. So interventional pulmonology is an emerging branch of respiratory medicines that we deal with invasive respiratory procedure. It's broncho and pleural. I've mentioned the pleural already for the chest drain, IPC, and pleuroscopy. So I will mainly focus on the bronchial procedure. So bronchoscopy, endobronchial ultrasound or EBUS, and the bronchial valve insertion, and then bronchial thermoplasty. We have covered this pleural procedure already in the first lecture. So bronchoscopy is very common endoscopy that we respiratory physician doing day in and day out. The indication is mainly for hemoptysis, unresolved pneumonia, abnormal chest X-ray, and chronic cough. Sometimes we will proceed. We do diagnostic mainly. Therapeutic is mainly for the pneumothorax, I will mention. For the asthma, we will do some therapeutic bronchoscopy. But for the removal of foreign body or insertion of stent, then we will leave to the surgeon. Okay, so we have to know the contraindication of bronchoscopy. If patient is having respiratory failure, in high flow oxygen, then it may be a contraindication because a patient, when we insert the endoscopy to the trachea, it will further compromise the respiratory status. If patient have low BP, is shocked, then we won't proceed. If patient have bleeding tendency, we usually take INR less than 1.5 before proceeding bronchoscopy, and platelet less than more than 50, platelet more than 50 before we proceed to bronchoscopy. If patient have recent stroke, MI, COPD or asthma, then we will delay the procedure because during the procedure, the blood pressure may be fluctuate, so it's not good for MI and stroke patient. And during the procedure, there's a risk of bronchospasm. So if patient have recent exacerbation of COPD and asthma, then we will defer the procedure. So this is a video showing patient having lung cancer. So this is the carina. You can see the carina is the mucosa is very abnormal. This is the left main bronchus. You can see the tumor is partially obstructing the left main bronchus. So all this mucosa is swollen and abnormal. And we will do a pleural, do the broncho biopsy by the faucet for the diagnosis of lung cancer. So this is the video showing a lung abscess. Usually there's nothing to see in the bronchus, but for this, the lung abscess is invading to the bronchial structure. So you can see that necrotic tissue over there. So again, when you take consent, you have to explain to patient the complication of bronchoscopy. So for the because this is under IV sedation, we will use fentanyl, that is opioid, and also midazolam, that is benzodiazepine for IV sedation. There's risk of hypotension, respiratory depression, agitation, allergic, and vomiting. This is all because of the IV sedation drug. And bronchoscopy-related complications include nose bleeding because we will use the nose approach sometimes, and bronchospasm, arrhythmia, hypotension. So if patient got infection, sometimes patient will have bacteremia after the procedure and fever. So more importantly is the complication related to biopsy. So we have to explain the risk of bleeding. Usually the bleeding can be stopped by spraying of adrenaline or tamponade the bleeding site, but still there's risk of uncontrolled bleeding causing suffocation, intubation, respiratory failure, or even death. If we do a transbronchial pleural biopsy, that's when the biopsy needle, the biopsy forceps is go through the end of the bronchus and then to the lung parenchyma and take biopsy. That's a risk of pneumothorax because we may hurt the visceral pleura. So we have to explain to the patient that if we do the transbronchial biopsy, there's risk of pneumothorax. And there's risk of infection or foreign body in area, but this we never got this happen, the broken equipment. So this all for bronchoscopy. And the second procedure I would like to talk about is endobronchial ultrasound. So there's a two type of endobronchial ultrasound. One is the radial probe. It's for the peripheral lung lesion. And then the second one is linear probe. Is for the mediastinal pathology. First indication is diagnosis and staging of lung cancer, and also some mediastinal lymphadenopathy. Then we will use the linear probe ultrasound and the bronchial ultrasound to do FNA and diagnose. So this is the linear EBUS. This is the radial probe. Radial probe, we just insert a radial probe through the normal bronchoscopy. But for the linear probe, we do not use bronchoscopy. The scope would be different. This is the EBUS scope. So preparation is similar to bronchoscopy, but the duration will be longer, and the complication is similar to bronchoscopy. So this is the ultrasound image for radial probe. You can see for the normal lung, the ultrasound is not visualized clearly. So if there's a solid lesion over the lung parenchyma, we will see an echogenic lesion here, and this is the lung nodule. So for traditional bronchoscopy, we cannot reach the peripheral lung pathology, but with this radial probe, we can go to the more peripheral area to take the biopsy. So the radial EBUS improves the diagnostic yield of peripheral lung nodule. Just for the glance, the sensitivity of bronchoscopy. With the radial probe of diagnosing peripheral lung nodules would be, the diagnostic rate would be 80%. If the lesion is bigger, then the diagnostic yield would be higher. Smaller, the diagnostic will be lower. Sometimes we will use this guided shift as during the procedure. So we will insert the radial probe with the shift, and then when we reach the tumor, we will remove the radial probe and keep the shift there, and then insert the biopsy forceps to the lesion. So it can improve the diagnostic yield, especially if the lesion is less than 1 cm. So for the linear probe is another kind of method, linear EBUS. This is the EBUS scope. And this is the ultrasound probe, and this is the needle. So the main indication is for mediastinal pathology, staging lung cancer and mediastinal lymph node biopsy, or FNA. So this is the lymph node that we can approach by EBUS. So usually it's around the trachea, under the carina, we call subcarina, and the interlobular region. So these are the lymph nodes that usually the lung cancer will metastasize to. So we can approach this lymph node by EBUS. So this is the sensitivity of diagnosing lung cancer by EBUS. So there's very high sensitivity. So when we the literature show that EBUS tDNA, that means transbronchial needle aspiration for diagnosis of lung cancer, have good specificity and good sensitivity. So classically or traditionally, for staging of lung cancer, patient need to undergo GA mediastinoscopy to take out the lymph node for mediastinal staging. But nowadays, it is totally replaced by endobronchial ultrasound. So this is one of the landmark papers showing EBUS is as good as mediastinoscopy in terms of staging of lung cancer. So the good thing is that patients do not need to undergo a GA procedure if EBUS can be done. So we do EBUS in the endoscopy center under IV sedation. So it just shows the sensitivity comparing EBUS and mediastinoscopy, and it's all comparable. So EBUS can have already replaced mediastinoscopy for staging of potentially resectable lung cancer. So this is the EBUS image showing the lymph node, a big lymph node here, and then we can stick a needle in to do the real-time FNA. So we can also do the Doppler ultrasound. You can see, oh, there's a big vessels here. So this is the lymph node. Actually, this is the as we see here. And then we do Doppler, or make sure there's no blood vessels over the lymph node. And then we will stick a needle in. And we will stick a needle real-time FNA during the EBUS. So this is, as we see, this is the lymph node. The needle will stick in, and then we will do agitation. So this is a real-time ultrasound guided fine needle aspiration of lymph node. So this is the endoscopic view. We will put the shift there and then stick a needle in. So this is the carina. We are doing the subcarina FNA. So there's some complication, rare complication of EBUS. On top of the complication of bronchoscopy, as we have touched the mediastinum area, there's a risk of mediastinitis. So this is one of the case reported in the international journal. So this is the lymph node before the EBUS. And then 2 weeks later, patient present with, 1 week later, patient present with fever, chest pain, and repeated CT show there's an infection over the lymph node area. There's a bubble, and the lymph node is inflamed, increased in size. So this can be settled by some antibiotics, and is usually non-fatal. So after talking about bronchoscopy and EBUS, I will go into some therapeutic procedure. So this is an endobronchial valve, we call EBV. This is a one-way valve, can let air out but not air in. So the indication of EBV would be emphysema for lung volume reduction procedure, and also for persistent air leak in pneumothorax to stop the air leak, and we can remove the chest string and discharge patient earlier. So endobronchial valve can be inserted through bronchoscope. We can do the normal bronchoscope, and then usually we will identify the air leak by using a balloon test to see if we occlude that area, then there's no more air leak, then we will put the EBV there to stop the air leak. So this is the delivery catheter. And then this is the target, and then we will put this and the bronchial valve like opening an umbrella and obstruct this segment. So this is a one-way valve. The air can be out, but no air in. So the lung this part will be collapsed and the air leak stop. So this is how the EBV look like. So this is a case of pneumothorax. Patient have persistent air leak more than 20 days, and we refer to surgeon, and he's not a surgical candidate. So we have insert the bronchial valve here in the chest X-ray, and the lung collapse, the air leak stop, and then we move the chest drain. So the second therapeutic procedure is bronchopneumplasty. So this is a bronchoscopic procedure for treatment of severe asthma. So this procedure target at the airway smooth muscle. This is the normal airway smooth muscle. This is the asthma airway. So the airway small muscle is very thick, and when it is attacked, that's asthma attack, it will cause bronchospasm. So the bronchopneumplasty is to reduce the excess airway smooth muscle. So this is patient with asthma. After bronchopneumplasty, there's a reduce in excess airway smooth muscle. So what is bronchopneumplasty? It's a new treatment for severe asthma approved by FDA like 10 years ago. Please remember, the first line treatment of asthma is not bronchopneumplasty, is inhaled corticosteroid, and also according to GINA guidelines, step 1, step 2, step 3, step 4. And then if patient is going to step 4, patient cannot have is uncontrolled asthma despite all the medication, and then we will consider biologic or thermoplasty. So it depends on the phenotype of the asthma. So this bronchopneumplasty is have proven to be reduce asthma exacerbation and quality of life at the 1 year and 5 year post-treatment for severe asthma. So this is the LL catheter system. It will deliver the radio frequency energy to the airway and then reduce this airway smooth muscle. So this is the video showing how the bronchopneumplasty done. So patient is intubated, and we do bronchoscopy and to the target airway, and then the radio frequency energy will be delivered there and reduce the smooth muscle over the wall, bronchial wall. So this is the canine model. You can see before treatment, the airway smooth muscle bulk, and after treatment, it's greatly reduced. So the literature showed that after 1 year, the quality of life has been improved, and there's reduced in asthma exacerbation, reduce systemic steroid use, and reduce the loss from work and school of asthma patient. Safety data is promising as well, but a patient will have asthma exacerbation after the procedure. So usually steroid will be given before and after the procedure. So for 5-year data, the clinical improvement still persists after 5 years. So the long-term data is also safe and effective for bronchopneumplasty. But please remember, this is not first-line treatment for asthma. It's for severe asthma that not responds to traditional therapy, and then we may consider bronchopneumplasty. So is there any question for this topic? Oh, that's other question for pneumothorax. Are there landmarks to measure the size of pneumothorax in chest X-ray? Oh, no, there's no landmark. Just the poor. I will show you in chest X-ray. Like the chest X-ray that I have. Yes. So usually we will just measure the pleural line and the chest wall here. Or sometimes the apex and the pleural line if just apical pneumothorax. Just like this, we measure here from here. Okay, I think it's more than 2 cm. So it's a big pneumothorax. So that's how the size of pneumothorax is measured. We take the largest distance, yes. Yes. We will present as there's a 2 cm rim or 1 cm rim or just 1 cm from the apical that is smaller. That would be smaller, right? Usually we just present like this. Is the criteria for primary pneumothorax and or criteria? I think it's or. If patient is 60 years old, even though patient is not COPD, we will classify as secondary pneumothorax. Young smoker with no feature of lung disease. Oh, yes, it depends on how young he is. If 20 years old, even he is a heavy smoker, we won't say he has COPD. We just classify as primary. If it's 50 years old or 40 something, then would be like, it depends how bad is the lung function and how heavy he is a smoker. So when do we apply suction to chest drain? Do we apply initially or when the lungs fail? Yes, it's a good question. After we insert the chest drain, we won't apply suction immediately because there's risk of pulmonary re-expansion, pulmonary edema. So if we insert the chest drain, we repeat the chest X-ray, the lung is not expand very well. Usually after 24 hours, if the lung is not expand well, we will apply suction. So this is expert opinion. There's no guideline on that, but don't give suction too early. Why do we do not have pneumothorax chest? I think you're asking the chest X-ray, diagnosing pneumothorax in the chest X-ray. Yes, one of the maneuver for increasing the sensitivity of diagnosing pneumothorax is that we won't do an inspiratory film. We do an expiratory film. Yes, this is one of the maneuver that can be used if there's you suspect pneumothorax. You suspect pneumothorax, but it's not very sure in the PA inspiratory film. You can ask for expiratory film. Sometimes it's more prominent in the chest X-ray, in the expiratory film. So yes, please focus on the pleural disease lectures. Pneumothorax and pleural effusion are very important topic for you. Okay, I think there's no more. Okay. Why not do an expiratory film? Yes, you can. If you suspect this patient, the standard chest X-ray is PA film, inspiratory. So usually you, for the first step of chest X-ray, clinically, if you not really suspect pneumothorax, you can the standard chest X-ray is PA film full inspiratory. But if this patient present with shortness of a sudden onset of chest pain and shortness of breath, you are suspecting pneumothorax at the first phase, then you can do the expiratory film at the first step. You can. Just the standard inspiratory chest X-ray in a PA film. Or do an inspiratory and expiratory at the same time is good as well. Okay, the flying advice, right? Yes, this is an important question to address to patient as well. If patient have pneumothorax, resolved pneumothorax, and that means there's no more pneumothorax in the chest X-ray, then we will advise patient not for airplane for 2 weeks to 6 weeks. It depends. Usually 2 weeks after the pneumothorax resolved. However, if patient is a pilot or diver, then we will refer to surgery before discharge. So both taking aeroplane and diving will increase risk of pneumothorax and can be fatal. Okay, if there's no more question, then thanks everyone for listening to the lectures, and you can email me if you have any questions. No, thank you.